Welcome to the deep dive. We're doing something a bit different today, really zeroing in on a topic for those of you prepping for the MSRA exam. We've got the source material you sent over, and we're going to pull out the absolute key high-yield facts. And today's topic is Pompholyx.
That's it. Yeah, the idea is to slice right through to the core information in those notes. We'll build up a really clear picture of Pompholyx, what it is, what might cause it, how you'd spot it, crucially, what else it might be, and how you'd go about managing it, all geared towards helping you revise effectively.
Right, like unpacking those notes into something really usable.
Exactly. Memorable for the exam.
Okay, let's start unpacking then. First things first, what exactly are we talking about with Pompholyx?
Okay, so Pompholyx, formally it's a type of dermatitis. You might also hear it called Dyshidrotic eczema or maybe vesicular hand eczema. The absolute key feature, the thing that defines it really, is this eruption of small blisters. They're usually fluid-filled and often, really often, incredibly itchy. And they pop up in very specific places, mainly the hands and feet. It's flagged up as a condition that tends to be chronic and recurrent. It comes back.
And the notes mention those specific names too. Chiropompholics for hands, Pathophysiology for feet. Makes sense. I also saw that little detail about the name Pompholyx coming from the Greek for bubble. Kind of paints a picture, doesn't it?
It really does.
Yeah.
Yeah, so fundamentally it's an eczema type affecting palms and soles.
Yeah.
An inflammatory skin thing. The exact trigger isn't totally nailed down, but it presents with this very characteristic itchy, bubbly rash. Could be a one-off acute flare, or might keep coming back, or even become, chronic.
So if the exact cause is unclear, what do the sources suggest might be going on? Any clues?
It's not like there's one single smoking gun. The thinking outlined in the material is that it's probably a mix. Some genetic factors making someone susceptible, plus environmental influences. There's mention of a possible link to abnormal sweating patterns and maybe some issues with the skin's natural barrier function. But, and this is really important, the kind of thing they love asking about, despite that old name, Dyshidrotic, suggesting sweat duct problems.
Yes.
When you actually look the skin histology under the microscope, there's no evidence the sweat glands are involved. So that name, it's actually a bit of a misnomer now. We know better.
Okay, that's a vital point then. So abnormal sweating might be linked, maybe as a risk factor, but the condition itself isn't caused by blocked sweat glands.
Precisely. That's the key takeaway. The inflammation in those vesicles, they're not forming because sweat is trapped. It's tied to the inflammation, the skin barrier problems, perhaps triggered by something else.
Right. So what are those triggers? What sort of things can set off a flare-up?
Well, the material lists a few usual suspects. Contact with certain allergens or irritants, think detergents, solvents, that kind of thing.
Okay.
Emotional stress comes up quite strongly as a trigger, too. And very commonly, you see it linked with warm, humid weather. High temperatures and humidity definitely seem to play a role in bringing it on for some people.
That fits with it being more common sometimes, maybe certain seasons or climates, which leads to who's actually more likely to get this? What are the risk factors?
Okay, looking at the risk factors pulled from the sources, definitely having a personal or family history of atopic conditions like eczema, asthma, hay fever, that's a big one.
Right.
Also, people whose jobs involve frequent exposure to those irritants we mentioned, or just lots of hand washing, lots of water contact. Excessive sweating or hyperhidrosis is listed as a risk factor, which links back to that sweating association, even if it's not the direct cause.
I see.
Psychological stress, again, fitting with it being a trigger.
Yeah.
And living in or traveling to warm, humid places. It all ties together.
Okay, got it. Now, let's go a bit deeper. Under the skin itself, the pathophysiology. My notes talk about these small, deep blisters. What's actually happening there?
Right. So on a sort of cellular level, the sources describe a process that involves the immune system not quite behaving itself, problems with the skin barrier, that protective outer layer, and resulting inflammation. The little blisters, the vesicles, they form within the layers of the skin, the epidermis and dermis. But, and I'll say it again because it's crucial, the histology shows no involvement of sweat glands or ducts.
The Dyshidrotic misnomer again.
Exactly. That old theory about trapped sweat.
Yeah.
Incorrect.
Okay.
It's key to remember it's inflammatory, linked to barrier and immune issues.
Got it. Inflammatory, barrier issues, immune involvement, not sweat glands. Super important distinction.
Okay, now, for exam revision, differential diagnoses are absolutely massive. What else could look like this? What mimics are listed in the source material?
Yeah, this is a really, really critical section. You see blisters on hands and feet. You have to think broader. What else could it be? And the sources give quite a long list. Okay, let's hear it.
Right, so you need to have in mind pustular psoriasis, especially the palmoplantar type. Fungal infections, tinea, can sometimes cause blisters. Bacterial infections, maybe like bullous impetigo. Something called recurrent focal palmar peeling, or keratolysis exfoliative. Then there are rarer blistering conditions like dyshidrosiform bullous pemphigoid or just standard bullous pemphigoid. For kids, acropostulosis of infancy or juvenile plantar dermatosis affecting the feet. Linear IgA disease is on the list, sometimes with hemorrhagic, sort of blood-filled blisters. And a really key one, contact dermatitis, both allergic and irritant types, which is tricky because, as we said, irritants can also trigger pompholix itself.
Right, so it can be hard to distinguish sometimes.
Yeah, exactly. The list goes on. Pemphigoid gestationis, that's specific to pregnancy. Pemphigus vulgaris, a very rare one. The dyshidrosis-like variant of adult T-cell leukemia lymphoma. Pityriasis rubra pilaris. Epidermolysis bullosa, that's a whole group of genetic blistering disorders. Subcorneal pustular dermatosis. Erythema multiforme. Even things like contact urticaria syndrome, fixed drug eruptions, simple friction blisters, and herpes simplex infections.
Wow. Okay. That is comprehensive. Definitely highlights why you might need investigations if it's not textbook or not getting better. That list is definitely worth reviewing a few times.
Absolutely. Knowing those differentials is key for safe practice and for exams.
Okay, moving on. Who actually gets pompholix? How common is it? What about the epidemiology?
Yeah. According to the material, the exact numbers for the UK aren't really known, but it's generally considered pretty common. It mainly affects adults, typically hitting people between the ages of 20 and 40 most often. There's also a slight tendency for it to be a bit more common in women than men.
Right.
But while that 20-40 bracket is the peak, it can happen at any age, really. You can see it in children, too. And reinforcing what you said about triggers, it's definitely more common in warmer months and warmer climates.
Okay, so let's imagine a patient walks in. What are the classic signs you'd be looking for on examination? What does pompholix actually look like clinically based on these descriptions?
The absolute hallmark is those small, fluid-filled blisters or vesicles. You'll find them typically on the fingers, often starting on the sides, the palms, the soles of the feet, or maybe the toes. And the symptom that almost always comes with them is the itch. It's often described as really intense, severe itching. Sometimes people also report a burning feeling in those areas. Sounds pretty miserable.
It really does. What happens to those blisters over time? Do they just stay there?
No, they tend to evolve. They can burst or maybe just dry up. And when they resolve, the skin underneath often becomes quite dry, and it can crack or peel. As we mentioned, the condition might be a one-off acute thing, or it can keep coming back in flares, or sometimes it just sticks around chronically. Looking closer at the vesicles themselves, they're typically quite small, maybe 1 or 2 millimeters across. And yeah, often starting along the sides of the fingers before spreading onto the palms or soles is a pretty characteristic pattern.
Anything else to look for?
You might see the surrounding skin looking a bit red, maybe sweaty, especially during a flare-up. And as the blisters resolve, you often see this sort of peeling or rings of scale where the vesicles were. They kind of unroof themselves.
I remember seeing something in the notes about nails as well, if the flare is near the nails.
Yes, that's right. If you get eruptions near the nail matrix, where the nail grows from, it can sometimes cause changes in the nail itself, like transverse ridges or furrows across the nail plate. It's a sign of the inflammation affecting nail growth.
Interesting. And how long does a typical flare last?
The source material suggests the vesicles themselves usually stick around for about 3 to 4 weeks, and then they tend to disappear spontaneously, even if you don't treat the blisters directly.
Okay, so you've seen these features. You suspect pompholix. How do you confirm it? Do you always need tests?
Usually not, actually. The emphasis in the material is that the diagnosis is typically clinical. You make it based on recognizing the characteristic appearance, the type of blisters, where they are. In straightforward cases, specific tests often aren't needed.
But when would you investigate further? What makes you think, maybe I need some tests here?
Right. You'd start thinking about investigations if the picture isn't quite classic, or if the person isn't getting better with the usual first-line treatments. And crucially, if you need to rule out one of those other conditions on that big differential list we went through.
Makes sense.
So the specific tests mentioned are, if you're worried about a secondary bacterial infection, maybe the skin looks weepy or crusted, then a swab for culture and sensitivity is a good idea. If you think a fungal infection could be playing a role, especially if it's not responding, a skin scraping or maybe even a punch biopsy might be used to look for fungus. Patch testing comes up too, particularly if you suspect contact dermatitis is the real culprit, or at least a contributing factor.
Right, given the overlap.
Exactly. And then there's that very specific point about ruling out the dyshidrosis-like T-cell leukemia lymphoma variant that would involve blood tests, serology for HTLV1, but only in very specific clinical situations where that's a genuine suspicion.
So mostly clinical, but tests have their place for tricky cases or ruling things out.
Precisely.
Okay, so we've got the diagnosis, or we're treating it presumptively. What's the management strategy? How do you actually help someone with Pompholyx, according to the sources?
Right, the main aims are pretty clear. You want to relieve those symptoms, especially the itch, which can be debilitating. You want to try and prevent future flare-ups. And you want to help the skin heal. Symptom control is a huge part of it. The sources describe a kind of stepped approach. First line, the basics. Emollients, lots of them, to moisturize and repair that skin barrier. Topical steroids, creams, or ointments applied directly to the rash to calm the inflammation and reduce the itch. And simple things like cold compresses can feel really soothing for that burning and itching.
Okay, standard eczema type approaches to start.
Pretty much. Other topical options mentioned are calcineurin inhibitors, like tacrolimus or pimecrolimus. Oral antihistamines might help with the itch, especially at night. And a really key part of management alongside the creams is identifying and avoiding any known triggers. That's fundamental.
Right. What if that's not enough for more severe cases?
If topical treatments aren't cutting it, then you move up. Oral steroids, like prednisolone, are listed as a second-line option for getting bad flare-ups under control quickly, but usually just short courses. For really severe, persistent, or widespread cases, more potent options might be needed. Systemic immunosuppressants are mentioned drugs like methotrexate, azathioprine, mycophenolate mofetil, or cyclosporin. These require careful monitoring, obviously.
Yeah, these are big guns.
They are. Other things mentioned include phototherapy, using controlled UV light treatment, which can be effective. Sometimes if you have really large, tense blisters causing a lot of pain, draining them carefully under sterile conditions can give relief. And of course, if it gets secondarily infected with bacteria, you'll need antibiotics.
Any other treatments mentioned?
Yeah, the material also briefly touches on botulinum toxin injections, which have shown some promise, possibly related to reducing sweating in the area. And it notes ongoing research into other things like systemic alloretinoin, a retinoid, topical bexarotene, newer biologic drugs like monoclonal antibodies, and even radiotherapy in very specific, difficult situations.
So quite a toolkit available, ranging from simple moisturizers all the way up to specialized treatments.
Definitely. It's about matching the treatment intensity to the severity of the condition and the individual patient.
Okay, last section then. What's the long-term outlook, the prognosis? Is this something people just get over, or is it more persistent? And are there complications to worry about?
The general picture painted by the sources is that Pompholyx tends to be a chronic and relapsing condition. So it often sticks around long term, and flares are quite common, even if people have periods where their skin is clear. The positive side is that for most people, the symptoms can be controlled pretty well with consistent management, using the treatments, avoiding the triggers. This often leads to remission, periods without symptoms, but the potential for it to flare up again is usually there.
The notes did emphasize that while the overall health outlook is good, it can really impact quality of life because of the symptoms. And while individual flares often resolve in 3 to 4 weeks, as you said, some people do experience a much more chronic, persistent course that's harder to manage.
That's true. It can be quite relentless for some individuals.
Right.
Complications. What should we be aware of? They're described as relatively rare, thankfully.
Yeah.
But secondary bacterial infection is probably the most common one. The broken skin from blisters or scratching lets bacteria in. That needs antibiotics. As we've touched on, the sheer discomfort, the intense itching, sometimes pain can significantly interfere with daily life, work, sleep, impacting overall well-being and quality of life. That's a major complication in itself.
Yeah, absolutely.
With chronic repeated episodes, the skin can sometimes become thickened and leathery. That's called lichenification. You might also see changes in pigmentation, usually darkening, called post-inflammatory hyperpigmentation. And finally, that link with stress, the condition can cause stress, and stress can worsen the condition, potentially creating a difficult cycle for the patient.
Okay, that gives us a really comprehensive overview of Pompholyx, pulling everything from that MSRA revision material. We've covered the definition, the potential causes, the risk factors, the actual pathophysiology, clearing up that dyshidrotic confusion, that huge list of differentials, who tends to get it, what it looks like, when to investigate, the whole range of management options, and finally, the prognosis and potential complications.
Yeah, so just to quickly recap the absolute essentials. Type of eczema: itchy blisters, hands and feet, Remember, the dyshidrotic name is a misnomer, not sweat glands. Triggers like stress, heat, irritants are key. Diagnosis is usually clinical, but keep differentials in mind. Manage with emollients, topical steroids, first line, plus trigger avoidance. It's often relapsing, flares usually resolve in weeks, but can be chronic and really impact quality of life.
Perfect summary. So here's a final thought to leave you with. We heard how stress is both a risk factor and a trigger, and how much the itching impacts quality of life. Thinking about that, how crucial might a more holistic approach be, looking beyond just the skin creams and considering psychological support or stress management for really helping patients cope with this condition effectively in the long run? Something to consider. Right, that wraps up this deep dive focused on Pompholyx for your MSRA revision. For more free MSRA revision resources, you can visit freemsra.com, and if you're looking for the full premium revision toolkit, head over to passthemsra.com.